This is a guide to assessing lung fields using the Bedside Lung Ultrasound in Emergency, or BLUE protocol, in a patient with acute respiratory failure. The BLUE protocol is a rapid, systematic examination that takes less than 5 minutes to perform and can help identify common causes of acute dyspnea with high sensitivity and specificity. For the diagnosis of pneumonia, the BLUE protocol has a sensitivity of 88% and specificity of 93%, compared with a combined reference standard of clinical suspicion, laboratory testing, and computed tomography imaging. This video provides an overview of the BLUE protocol and its interpretation. The BLUE protocol uses a microconvex probe, which may not be available at all institutions. If you do not have a microconvex probe, you will need both a high and low frequency probe to improve diagnostic accuracy. The low frequency probe, such as a curvilinear probe, is used to assess for sonographic artifacts of the lung, such as B-lines or consolidation. It can also be used to assess for lung sliding. The high frequency or linear probe is used to assess for lung sliding at the pleural interface, in instances where it is not immediately apparent with a low frequency probe. The BLUE protocol uses 6 standardized scanning points, 3 on each side of the chest, referred to as BLUE points. To find the BLUE points, place both hands on the anterior chest. The upper hand's 5th digit is just below the clavicle. The examiner's fingertips are adjacent to the sternum. The upper BLUE point lies at the center of the upper palm. The lower BLUE point lies at the center of the lower palm. These points assess the upper and lower anterior lung. The third point on each side is called the posterolateral alveolar and/or pleural syndrome point, which assesses the posterior lung. It is located at the intersection of a horizontal line extending from the lower BLUE point and a vertical line descending from the posterior axillary line. We will now demonstrate how to scan using a curvilinear probe. Begin anteriorly on the patient's right side. Place the probe at the upper BLUE point with the indicator pointing cephalad, or towards the head, and identify the pleural line, the bright or hyperechoic horizontal line between 2 rib shadows. After visualizing the pleural line, assess if there is lung sliding present. This is characterized by a to and fro movement with each breath, which represents the visceral pleura moving against the parietal pleura. After determining if lung sliding is present, use the low-frequency probe to assess for lung artifacts, including A-lines, B-lines, or consolidation. A-lines are horizontal reverberation artifacts that appear parallel to the pleural line at regular intervals. B-lines are vertically oriented, hyperechoic, or bright artifacts emanating from the pleura. Consolidation manifests as an irregular pleural line with denser hyperechoic lung tissue that may resemble a liver's echogenicity, a phenomenon called hepatization of the lung. After completing this assessment, move to the next BLUE point on the lower right anterior chest and repeat the same examination. After assessing both the upper and lower anterior points, move the probe posterolaterally to assess the right posterior lung. Slide the probe as posteriorly as the patient's position allows to ensure it is in the posterior axillary line. Repeat the sequence on the contralateral left hemithorax at the upper and lower BLUE points, and lastly, the left posterior lung region. Here are some tips for troubleshooting. If lung sliding is not immediately apparent or equivocal in any lung zone, switch to the linear probe, which has a higher sensitivity for lung sliding. If the pleural line is not immediately visualized, slowly tilt the probe back and forth to improve its visualization. If the posterior lung is difficult to assess, have the patient or an assistant elevate the arm above the head to allow for sufficient access. There are distinct profiles suggestive of pneumonia. The C profile is any visualized consolidation and can occur with or without lung sliding. Second, the AB profile is characterized by B lines confined to a single hemithorax and can occur with or without lung sliding. Third, the B prime profile, which involves B lines located in both hemithoraces without lung sliding, may also indicate pneumonia. The B profile is characterized by bilateral B lines in the presence of lung sliding and may indicate pulmonary edema. The A profile is defined by the presence of lung sliding in all anterior fields, and only A lines are visualized. The posterior lung should then be evaluated. Any abnormality, such as B lines or consolidation, is suggestive of pneumonia. If there's no abnormality, then the patient should be assessed for deep venous thrombosis with lower extremity compression ultrasonography. Identification of deep venous thrombosis may suggest pulmonary embolism. If absent, then obstructive airway disease such as COPD or asthma may be considered. The A' profile indicates the absence of lung sliding in anterior fields, and only A lines are visualized. If present, pneumothorax should be considered. Using the Blue protocol has demonstrated good diagnostic performance in patients with acute respiratory failure.